Chair.
No worries. No worries at all, David. My background is flashing orange yellow, so that's great.
And I take as a really positive that Chris sees me as modern man. I am very pleased with that. In fact, perhaps I should quit whilst I'm ahead, Chris.
The meeting is live.
Thank you, David. Panel members of the Health and Wellbeing Board and listening public, thank you. Welcome to this morning's meeting. As has been the case now for quite some time, I have a formal introduction to read out, which sets out the reasons why how we can hold this meeting in a virtual setting. Due to the coronavirus pandemic, the Council will be holding this meeting electronically in accordance with the relevant regulations. Members of the public may also attend this meeting in electronic capacity, and there is a link on the Council's website for them to do so. Members of the Council are asked to keep their microphones switched off until called to speak, and to switch their microphones off once they have finished speaking. Cameras may be left on throughout the meeting if members wish. If you experience connection or other technical issues, it may help to switch your camera off. Cameras should be switched on if and when speaking in the meeting. To indicate a wish to speak, members should use the raise hand function. Use of the meeting chat function is exclusively for voting. At the end of the debate, on each item of business, there will be a vote. Members should vote using the meeting chat function by indicating for, against, or abstain. I will declare the result after each vote. Breaks of at least 15 minutes will be held every 2 hours and will be taken after a speaker in the debate has finished speaking. If we are voting, the vote will be concluded before the break is taken. Other breaks will be incorporated as appropriate. So, ladies and gentlemen, thank you and welcome to this morning's Health and Wellbeing Board meeting. I've had apologies from Nicholas Small, Chairman of Hearts Valley CCG, Tom Cahill, Chief Executive of the Mental Health Trust for Hertfordshire, and Councillor Tim Hutchins, who has a cabinet responsibility for public health, and Richard Cassidy, Chief Executive of East Herts District Council. Avni Shah, I am delighted that you joined us this morning to substitute for Jane, who is here, I have seen, but we will have to leave part way through the meeting. So thank you for giving your time to join us this morning and make sure that we have quoracy. And as this is proving problematic, we will look at quoracy as to exactly what we need for the future. Paul Burstow, thank you for joining us. I saw you come in there. We'll need to leave at various times during the meeting and then reappearing, not a problem. And Jim McManus is going to leave for another meeting after he has finished speaking. And Elliot Howard-Jones from HCT will need to leave this meeting at midday. With the following wind, this is the kind of agenda where I'd hope we'd be done by midday, but let's see how we get on. I have in the past asked you to introduce yourselves, but we're not going to do that this morning because we know each other and there's a familiarity now. And also, you're quite confident, and I can see happy to have yourselves on the screen as well, which is perfectly acceptable. So listening and watching public can see who you are, which is great. The minutes of our meeting of the 4th of December, quite some time ago now. Can I first of all just are those agreed in terms of accuracy? Is there anybody who does not think that they are accurate? If you could please indicate. David.
Sorry, yes, I'm certain I gave my apologies for the last meeting, but I couldn't see them when I looked at it. It might be that I misread them, but I couldn't see them, and I thought I will raise that. It was my birthday, and I wasn't there. Sorry.
There we are. That's almost a legitimate excuse. We probably felt your presence and included you anyway. But
at least we can say I did as much as I normally do at a meeting, which would have been more of a.
Thank you, David. Noted. And in terms of any matters arising, does anybody any comment on the minutes? And I have none. I've just I was saying in just before the meeting started, and I'll say it for the record, I will contact Mrs. Barr after this meeting to make sure that her son, severely disabled son, has received his jab, because since we had the meeting, we took as a system the decision that we would, in terms of vaccination, we would look favourably on all of those with a learning or a physical disability to ensure they got jabbed as soon as possible. And I'm really pleased that in Hertfordshire we chose to do that. And I shall leave it at that, but I will just double check with Mrs. Barr that everything's okay with her son. Thank you very much. I'm not picking up any more. I've just heard that Martin Steers Hanscom sent his apologies, so thank you for that. That can be noted as well. Thank you. Public questions. This meeting, there are none have been sent to us. Nobody wishing to ask a question. So Jane, I'm delighted that. Well, can I just say perhaps a couple of things. I have been known in the past to proudly wear my care badge, and I was scrabbling around looking for it. I have no idea where it's ended up, but I was scrabbling around looking for it and thought, actually, I wanted to wear a care and NHS badge. So if anybody's got a spare NHS badge, which I could add to my care badge, I would willingly wear both of them. And I think that would be in the spirit of the Health and Wellbeing Board. And it's only taken me 2 to 3 years to work that out. But so better late than never. Thank you all. For those of you who also have badges for the voluntary sector, for local government, for other forms of local government, for the Health Watch, I'm sorry, but those would be the only two I'd consider. But there we are, as an aside. And the other, just in passing, but not really for further debate, how much I, and I suspect others, welcome the opportunity to bring permanency to the ICS. And whilst there are 1 or 2 issues that need sorting out, I think we really do welcome the opportunity to work closer together and to make the very best of the opportunity in Hertfordshire, and at the moment it is in Hertfordshire and West Essex, to bring social care and health together for the best outcomes for our residents. I think that is the spirit within which we want to take forward those white paper proposals. Thank you. And so, Jane, if I could ask you to let us know how the vaccination programme is going in the county. And so over to you. Thank you very much.
Thank you very much, Richard. And apologies again that I have to leave the meeting partway through. But as you've noted, I'm joined by Avni Shah, who is our Director of Primary Care Transformation, who has been leading a lot of the work, particularly with primary care on vaccination, who will help me with the presentation and then stay when I have to leave. I have a presentation. We're doing it as a presentation simply because the data moves so quickly that anything that we had pre-prepared and circulated would already have been out of date. So hopefully people will bear with us with the format, and we'll see see how well we manage to get on. But if I then pop into the screen, the presentation. Please bear in mind that while I'm talking to this, I can't see people's hands or anything. So
that's coming through fine, Jane.
Yeah, but so I'd prefer I'll pause and take questions, but you'll have to shout, Richard, so that I know that people are raising their hands.
Okay,
so,
no worries.
What we've got now is a widespread and well-established vaccination programme across Hertfordshire and West Essex. We don't apologise for including West Essex in this, because clearly, given that much of the vaccination is being delivered by primary care, and primary care registered patients on both sides of the county, around Bishop Stortford and Cheshunt and into West Essex, there is actually a genuine degree of relevance in both ways, which it's probably helpful to have a line of sight on. The programme, as we've touched on before, is being delivered through a mixed economy, if you like, of vaccination. We started out with hospital hubs, which really are only doing predominantly healthcare staff and some care staff as well, so are not a mainstay of the ongoing vaccination programme. So we haven't sort of dwelled on them here particularly. We have a number of primary care sites through our primary care networks, or PCNs, right the way across Hertfordshire and into West Essex, and they so far have been the mainstay of our vaccination programme, providing around about 3/4 of all of the vaccines, and you can see those picked up in the blue, yellow and red. We have also a programme of mass vaccination centres which have been coming incrementally online, offering additional capacity, obviously starting, as I think members are well aware, with Robertson House and Stevenage, and continuing to set up additional sites, the last of which is due to go live next week. And we also have a number of community pharmacy sites, which are shown in the pink. So that's just to orientate people a little bit. Again, nationally, the programme is being driven by priority cohorts and moving on to lower priority groups as progress is made with the higher priority groups, higher priority reflecting risk of serious COVID illness or death, and therefore very heavily driven by age cohorts. Where we are at the moment is focusing very much on getting through as much as cohort 5 and cohort 6, seen in the middle here, as possible, but also starting to invite people in cohort 7 and 8 to come forward and book vaccinations, but booking ahead to have a sort of a supply line of willing arms as we are able to match it with a supply of available vaccine. It is anticipated that before the end of July, that nationally everyone will have received or been offered the opportunity to receive a first dose of vaccine, and our local planning suggests that we may well be ahead of that deadline in Herts and West Essex, subject to availability of vaccine supply. In terms of uptake, as to the end of last week, it's summarised overall on this chart, which is showing you daily change. So it's very granular information. It's flagging those different age cohorts predominantly that we saw on the previous slide. And I'll just sort of talk through a few of the headlines. We are extremely pleased, I think is the first thing to say, about the very high levels of uptake that we have seen in all of the groups to date. There's been a huge appetite seen in our population to come forward overall, and a very significant programme of cooperative establishment of sites, whether those are primary care or vaccination centres, to maximise local or as local access to vaccine as is commensurate with the fact that it needs to be driven by relatively high volumes because of the number of doses in each vial of vaccine. We compare very favourably to other ICS areas in the East of England, and East of England overall compares very favourably to the national picture. So this is a picture of pretty significant success to date, but grounded in an immense amount of hard work across a huge range of people, including our volunteers, who have been a huge help in all of the larger vaccination sites in different ways. As you can see, there's a what appears to be a sudden reversal in one of the groups, clinically extremely vulnerable, shown on the dotted black line. This actually reflects a change in the denominator, where a number of additional people were identified as being clinically extremely vulnerable, and therefore the number of vaccinations clearly has been going up throughout this period. What happened is, like I say, that the number at the bottom got bigger in a step change. Due to an algorithm being used to increase identification of at-risk people. There's further information on other slides, so I'll move on and just sort of, because some of the detail will come out more clearly through the other slides. In terms of how do we look across first and second doses profiled by those cohorts, mainly age driven, again, you can see very reassuringly, I think, that the uptake is pretty even right the way across the geography. There clearly are at a lower level some variation, but we're not seeing any significant difference across the whole of the geography. And we're obviously starting now to move into second doses in larger numbers, really from about this week onwards, as we're round about the 12th week from the initial rollout, and those numbers of second doses and completed vaccination will grow now incrementally and significantly over the coming weeks and months. When we look at the uptake of vaccines in relation to different ethnic groups, it needs a couple of minutes, I think, just to pull some of the strands out. I think the first thing to say is, again, broadly similar picture across the three place-based lenses, the two Hertfordshire CCGs and the West Essex CCG. What there are, however, are reasonably clear differences in uptake rates across some of the different ethnic groups, but you do have to bear in mind some of this is very small numbers, and some of this is also as much a reflection of the age profile within these different ethnic groups as necessarily purely an uptake issue. So, for example, an ethnic group which has a larger proportion of much younger patients, relatively few so far will have been invited in the older age range. Having sort of put those two caveats out there, there are some differences that I think we are beginning to see more clearly. So, for example, we can see in our Irish group, for example, actually very high levels of uptake, and similarly, or comparatively similarly in people of Indian background and Asian, other Asian backgrounds. However, in groups like white and black Caribbean, white and black African and African, we're seeing lower groups coming forward for vaccination, and as we've only really begun to get meaningful data around ethnicity at a local level within the last few weeks. So as we get more data and more used to working with it, we will be working very hard to start to tailor vaccine interventions to increase uptakes or increase the chance of uptake in groups that are currently underrepresented. One small example of this is we actually have we're running an internal staff webinar, which is being delivered by some of our medical staff from groups such as African backgrounds and others, to try and encourage the opportunity for staff to express concerns they might have around vaccine hesitancy, which we think is driving a lot more of this than outright vaccine refusal. People just feeling uncertain and insecure and wanting and needing a little bit more information before they're happy to come forward and be vaccinated. In terms of as I said at the beginning, around about 75% of our vaccination is being delivered at the moment by our primary care networks. This slide gives you a sense of how the different networks are performing. Again, I think the main message is they're all performing really very well. Even those that might appear to be slightly lower performing, a lot of this is driven by access to vaccine supply, which over the last few weeks has been much more restricted than we're expecting to see from next week onwards. So I think that's a reassuring slide from our point of view. I will not just sort of speak to this briefly. This is here just to show you the level of detail really that we go into in tracking some of the information. So this shows the over 65s in homes. You can see that we're actually tracking by day. We're counting the cumulative number of vaccines delivered, the number of patients remaining to be vaccinated, and this forensic level of detail that really is being worked through in these sorts of areas, and obviously working really closely with Chris and others, because the care home population is a changing population. People move into and out of care homes or transfer between care homes. So it is quite challenging, as well as care homes that have had outbreaks and where we have not been able to vaccinate either groups of residents or individual residents. So it really is being monitored extremely closely. I'll skip over this because it's broadly similar, just sort of looking through. In terms of tracking healthcare staff, touched on trying to drive up any variation between uptake between staff from BA and E backgrounds and staff from other backgrounds. This gives a pattern of vaccination across the main providers within the local area. Again, I think the positive thing is to note that the percentage of the percentage of staff taking vaccination up is actually really pretty high across the board. There is clearly a slightly lower uptake with staff from BA and E backgrounds, and that's not always quite the same by trust. But again, that is in part a reflection of numbers. So, for example, for Hearts Community Trust, where they have a smaller cohort of staff, then clearly a small increase in people who are hesitant about vaccine will lead to a larger percentage change than it will in a larger staff pool. But all of the trusts are working really closely with their staff to continue to encourage people to come forwards and take up vaccination, and using similar initiatives to try and counter vaccine scepticism or hesitancy. And we have worked really closely with the local dental committee, pharmacy committee and optometry committee and others, such as independent physiotherapists, to ensure that wherever we know that there are healthcare staff, even if they're not directly employed, Richard, as you said, with the blue NHS lozenge somewhere, that they still are able to come forwards and receive vaccination. We've been doing a lot of work recently to look at the capacity to sustain vaccination as numbers increase across the programme. And moving into those lower age cohorts, as I said at the beginning, we're really pleased that we've done extremely well, but the reality is so far we've done around about a first dose to 30%-ish of the population. We therefore have still the lion's share yet to come, and we are planning to really be ramping up delivery of vaccination in the coming weeks. We are looking at those areas, therefore, where perhaps the delivery might be a little bit more fragile in terms of ability of workforce to sustain it, or indeed areas where we haven't had perhaps as high an uptake, and trying to make sure that what we're doing is putting additional capacity and resilience into those areas that need it more than the areas where actually they're really coming along very nicely. And this sort of tweaking of capacity and tailoring of delivery models is going to be, I think, increasingly part and parcel of the programme from now on. So, for example, looking at drive-through or pop-up type approaches to try and capture people who may be more hesitant, but actually bringing the service to where they are, making it easier for them to access, and perhaps less easy for people to kind of put it off to another day. And as we do that, we'll be happy to sort of keep the board and members updated. So again, just a sense of the the detail that underpins this, not expecting anyone to particularly need or want to go through every line of this, but essentially looking at at each district council area, what population we're looking to serve, what we think the maximum weekly supply of vaccine under different delivery scenarios could be, and mapping that against what we know to be the current capacity, but also the maximum capacity that our work with vaccination centres and PCNs has told us could be switched on or developed in a relatively short space of time, and then doing additional work with those where we have a slightly higher level of concern. So just to finish what I hope hasn't been too dull a presentation, what we are currently focusing on at the moment, as I said, we're very much around sort of cohort 6, the carers and vulnerable, and are looking also at our inequalities groups. There's been work going on already to take vaccine out to the known traveller sites in St Albans, for example. There's been work done similarly to take vaccine out to the homeless. You mentioned right at the beginning the decision that we took to really try and maximise vaccine coverage for those with learning disabilities. That has been a strategy that has been successful in terms of actually delivering more vaccines. So you can see there that's actually a very high percentage compared to many others. And similarly, I know over particularly the early part of February, councillors, district and county councillors were getting concerns from housebound patients saying, I haven't yet been contacted, and that's partly has been a nature of the slower speed of delivery of taking vaccine out to individuals. But even then, housebound patients now over 80% vaccinated. Jim may well pick up later in his presentation the output areas data, so the lower geographical area data, allowing us to increasingly target vaccine delivery to particular communities around particular inequalities and other challenges. And as I've touched on, going through the specific work we're doing to try and drive up BAME health and care workforce uptake. One of the areas that has been lower has been care home staff and domiciliary care staff uptake. So again, working with Chris and others to try and really make inroads into that. So that is all that I wanted Richard to say. So what I will do is take that out of the box and then I can see people again.
Jane, that's really, really helpful. Thank you for your presentation. It wasn't boring at all. It was really informative. I think it's just what the Health Wellbeing Board and those that might be watching would want to know. My reflection on it, and I'll bring others in a moment, but my reflection is that you've got something like 85% plus of the over 60s. And my understanding is they are the most vulnerable to serious complications in hospital and possible death, and that is just fantastic. There is a question for me. I don't know whether you want to pick it up, Jane, or maybe Jim, or a combination of both. But and it is a broader question, I suppose, which is, what is the herd immunity, if that is the right language of now, that we think we need to give the population a fighting chance come this autumn, for example, to withstand the pressures of COVID. But can I just say to you and your colleagues and everybody involved in the vaccination programme, including volunteers, for us to be in this place now in the first week of March is just absolutely fantastic. So I'm really, really pleased for this rollout of the vaccination programme, and the way you've gone about it. It's worked very well. So thank you. Jane, I don't know if you want to just hold that thought for the moment, and I'll bring in David Lloyd.
Thanks, Richard, and thanks, Jane. I mean, I think that we're in a really brilliant place. There's a real success story to celebrate when the time is right to celebrate, and I think the rollout has been excellent. And I recognise that the focus has been, we've learned all sorts of words, haven't we, over the last year that we'd probably never have used in daily life, but the difference between mortality and morbidity, and clearly the focus has been on mortality, stopping people dying, and then sort of those who are seriously ill, the serious morbidity is the next focus. And I recognise that, but you probably know where I'm going with my hat on as Police and Crime Commissioner, because I really am disappointed, and we have had, I know I've been briefed by the appropriate person from JCVI, but I really am disappointed that frontline police officers have not been early in the vaccination program. I know that we've got a workaround which says that those vaccines which otherwise would be wasted rather than being thrown down a drain are put into the arms of police officers, and that's brilliant. And I think probably about 800 police officers have so far had that opportunity, and that's brilliant. But the message we're sending out to police officers by not giving those who are on the front line and are probably at a higher risk of catching, although not getting seriously ill because of their age, but the message we're giving to those police officers is we don't really care about them. And I just wonder whether or not there isn't an opportunity almost unilaterally for us to decide, look, let's just do it. Let's do it for police officers. Let's just show that we believe that they are putting themselves on the front line at risk. And I would have thought that ensuring that they don't transmit, and I'm not sure what the evidence yet is on transmission, but I would have thought that not having COVID is not getting the disease is a good starting point for not transmitting it. You know, I would have thought even on that basis it would make sense, and I just wonder why we're not doing that if we're able to, and if we're not able to, I'd just like that sort of said again, so that on the record I've said I really wish, as I know the Chief Constable does, as I know that Home Secretary does, I really wish that we had these vaccinations.
Thank you, David. Your point is well made. Jane, just before you come back, I'm just going to bring in Jim, who may have a view on this as well. I might have my own comment to make, but then come in to answer Jane. Thank you.
I think on so I guess the 3 points really, Chairman. The first thing is we are doing much better than we thought we would, and our NHS colleagues are doing much better than we thought we would. And despite, I mean, Jane has identified some inequalities in take-up, which we do need to work on. They are much lower or much smaller in the gap than they are in London. So, you know, we're by the gap between our least vaccinated and most vaccinated take-up is about a third as high as it is in London, and has narrowed, in fact, over the last 3 or 4 weeks. That's not being complacent. We've got a lot more to do. We really have got a lot more to do, but I think the message is getting across that take your vaccine. I think the third thing is on the herd immunity or population immunity threshold. It's difficult to calculate because we're not certain yet that the vaccine stops asymptomatic transmission. This isn't yet a disease that is eradicable by vaccination. It might become so, but we can't say that for certain yet. So you're looking at least 75% as a mid-range of the estimates for population immunity threshold, but we will still need to keep going with all the other measures. So it's the vaccine plus everything else, and we need to give the vaccine a helping hand. But, you know, by God, our colleagues are knocking this out of the park.
Thank you for that, Jim. Do you want to come back, Jane?
Yeah, so if I sort of respond to David's point, there's a number of strands. David, as you sort of referenced, this is a national policy which is underpinned by the advice given by the Joint Committee on Vaccinations and Immunisation. So the short answer is no, there isn't an opportunity to do something unilaterally and locally. But just to so the second point to make is we have seen with health and care workers the morale boost that has been part of staff being offered vaccination. So on a employer and human basis, I absolutely understand the point that you're making. However, the basis on which vaccine is being rolled out is to prevent serious illness and death. And the biggest drivers for serious illness and death are age, deprivation, and to a certain extent then modifiable factors around chronic disease and obesity, but those are themselves linked to age and deprivation. So just at the risk of sounding glib, given that the serving police force predominantly are not elderly, and by nature of being in employment and receiving a decent wage are not usually deprived, they aren't in the higher risk categories, albeit the nature of their work exposes them to large numbers of the public and they don't have the option of working from home. So I suppose what I'm trying to do is reflect the reality of, I do absolutely understand the point that you're making, but I think there is something here for us to continue to give as much reassurance as we can to our staff that it's not an abrogation of understanding, but there really is a rationale behind this. And certainly the work JCVI did looking at patterns of serious illness in death by occupation really identified only frontline health and care social workers as being at really significant increased risk. And they were extremely concerned that starting to bring forward different occupational groups would slow down the overall rollout. And therefore their compromise option was we keep going using age as the biggest proxy indicator, and we get people done fastest that way. And the sooner the population is covered, to Jim's point around not knowing what herd immunity probably looks like and not fully yet understanding the difference between illness and transmission, our best strategy is to maximise population coverage, and that's what we're doing.
Jane, thank you for the comprehensive answer. That's appreciated. Just as an aside, only this week I raised the issue about the prisons in terms of whether prison officers and prisoners should be vaccinated, and I got this very similar answer. I guess something similar around teachers. But then I started to think about more broadly, everybody in the workplace who can't work from home is probably in a similar situation. And as we move down into the younger age groups, it becomes an issue for all of us. And therefore, how do you choose a priority? So I absolutely sympathise. I think all of us do with our police officers who are on the front line and the contact they have. But it is a similar issue across many of our working age adults now, just adding to what Jane said. But thank you for making your point, David. And Steve, you wanted to come in.
Yes, thank you, Chair. Just to say, Healthwatch has been doing an independent survey of the patient experience around vaccine. And I have to say, we've had it's been going a couple of weeks, had about 1,200 responses so far, and it's been very, very positive. I think patients out there have really been very appreciative of the effort that's gone into it, not only to get it done, but actually the way it's been done. It's been very professional, very, very quick. People have been booked for a time and they've arrived at that time and actually had the injection on time. So I think we've had a very, very positive experience. So I just thought I'd share that with it. On a personal note, it's my 65th birthday a couple of weeks ago, and my day out for my 65th birthday was to get my vaccination. So I think you can't get much more efficient than that. So thank you very much.
Brilliant. That's great. That's great to hear, Steve. And I hope you have an opportunity to I don't necessarily shout that from the rooftops, but to make sure that your survey work is out there with the general publicity. Mine is coming up in a week or two's time. Looking forward to it. And in fact, I'm going to circumvent the 3-month need by having it done in both arms at the same time. That should help. But probably moving on rapidly. My apologies. Is there anybody else that wishes to comment? Can I just add also, just waiting to see, Prague wants to come in. Prague, feel free. No, it's my cursor. Apologies. Just to say, this was the week that care homes were able to reinstate and reinvigorate and personalize visiting, which is so important, and just personal contact is just so important, and the vaccination program with that very high percentage in care homes helps enormously. And picking up Jane's point, really important that we have as high a percentage of our care staff are vaccinated as well, and that, I'm sure that point is really is picked up. Thank you very much. Sorry, Prog, having prodded you, Prog, did you want to say something?
So I wasn't going to, but I think I'll take the opportunity now that you've called me to say thank you to the vaccination team that have been running this program. They've put in an incredible amount of effort, extra time, out of hours, all of that. And so thank you to them. And Jane has already said about the voluntary sector. Thank you again to the voluntary sector, because I think going forward to sustain this program, we're going to need more and more support from the voluntary sector. So we really appreciate that, and thanks again to everybody.
Thank you. Was there? Thank you, Prog. Yes, there's a lot of volunteers that hung around in a lot of cold car parks as part of this process, and they are. Let's just take our hats off to them. Absolute stars. Thank you. I think I've all the speakers notified. Probably easiest for me if you simply flag in the usual way. And then Jane can pick up in chat as well, but I will look that way. Jane, can't thank you enough for your presentation. That really helps us to understand the situation in Hertfordshire, and it's really positive. But then just finally picking up your point about we're only 30% there. There is still a long way to go, even to meet Jim's sort of 75%. And the word of his caution is resonating with me. So we still have a significant journey over the next few months. Jim now wants to come back. Jim?
Thanks, Chairman. I guess it's just to go back to what Jane is saying, and I'm sure if we could make up vaccination policy unilaterally, we may or may not do things slightly differently, because as Jane says, the rationale is preventing death, and we're now, as of this week, vaccinating people 55 and over, and government has decided for whatever reason that what we will do now is vaccinate everybody by age cohort, because it will be quicker than vaccinating key workers. So there are two things to draw from this. Firstly, whatever we might think personally, and I have views, we all have views about prioritising teachers and police, and we won with carers. We because that was a very strong rationale that motivated death. The government's prioritised death at the minute. We have to remind everybody that the vaccine isn't a silver bullet, because it is risk of death. So even if you're fully vaccinated, you will still need to take hygiene measures to protect others, and if you're unvaccinated, until every adult in England is vaccinated. So it's not, we have to get that message across that the vaccine in and of itself is not your protection. And actually, now that they're vaccinating people over 55 and all the clinically vulnerable, the vast majority of people who are at serious risk of death in England are now already well on their way to having a first dose, and many on their way to having a second dose. So I think we need to put it in that context. But that means that people like the Health Protection Board then have to do everything in their power to make schools as safe as possible, and make frontline policing and everything else as safe as possible. So I think we've got our work cut out for us for the next few months. And
you're echoing this need for, in a sense, personal hygiene vigilance to be just as high as ever, so that the hands and space and face, just maintaining the messages, just as we've had for many months, running into over a year now. Jim, I imagine we want you to keep banging that drum and getting those messages across, and varying how we do that. And I know we've been doing it in lots of different ways. I'm grateful. I think we should move on. I think that has shared the key messages around the vaccination programme. Jane, keep going. Thank you. And I think by the time we meet next time, we really will have made some. We should be probably very close to the magical sort of 70, 80, 90% mark. So thank you very much. Is there anybody that disagrees with noting this report rather than us all pinging off in agrees? I can see no dissent. That's fine. We'll move on. Jim, you've probably covered some of this already, but could I ask you to give us an update on the COVID situation in the county, which of course has changed dramatically since we met on the 4th of December. In fact, we've had a whole wave since we last met, a very sobering experience for all those involved. But Jim, over to you. Thank you.
Okay, thank you. I'm going to share a couple of dashboards and some slides, and obviously people are welcome to the slides. So hopefully this will share. And here it comes. So this is our surveillance dashboard, and as you say, Richard, we've had a significant kind of set of challenges going on since December. If you look at this graph, this shows the rate of cases in Hertfordshire. Now, you remember when we were really worried way back in September when we were about 24, 25 per 100,000. Well, we're still above where we were in September when we were worried. So we are going very much in the right direction. Look at that massive peak, and things are coming down significantly. And even if you look at Broxbourne, which was significantly higher than the rest of Hertfordshire, 1,500 cases per 100,000, that's all going in the right direction. Stevenage, there is, as we know, there's a gap between Stevenage and the rest of Hertfordshire, but the gap is narrowing and it's coming down. So everybody is going in the right direction. But Hertfordshire was higher than England, is now lower than England. We're still just higher than London in the green. So we're not out of the woods yet, but all the signs are going in the right direction. We've heard about the vaccine uptake. If we look at the rate of case rate, just because I fancy bamboozling you with statistical terms, really, you can see that the rate was accelerating all the way up until just before Christmas, and then it took a nosedive, accelerated again, and nosedived, and is now a negative rate, so we're in decline. We want to keep it there, and that's down to the residents of Hertfordshire. Lockdown has had an impact. We also know that the vaccination has a significant impact on the number of people being hospitalised, but the rate of cases is declining. The positivity is also declining, so it was over nearly one in 4 people testing just before Christmas were testing positive. It's now 1 in 13. That's a really good sign to be in. The average contacts most people have, we had a bit of a spike, but they've now gone back down again. We want them to be as low as possible until we open up, and when people can open up, we can open up more safely. The bulk of exposure categories now remain household transmission. That will change, so we should expect, as we come out of the restriction measures, that among the things we will see will be an increase in transmission and an increase in the R number. So the next few months are going to be bumpy. They are going to be a bumpy ride, and we need to be prepared for that. And in terms of the roadmap, if I share these slides, so the Health Protection Board is busy rewriting the local outbreak plan, which has to be with government by Friday, so no pressure there then. I think the journey for the next few months is to find a way of exiting the pandemic phase of this virus and managing the endemic phase, where the virus is circulating. It's not immediately eradicable by vaccines, and we are going to have it around for some time until we can get rid of it. And I think our choice is either really try and get rid of it ultimately by vaccination or by managing it out, or it mutates to the point where it's so mild it's no longer of public health concern. But for the minute, it's vaccination plus is our strategy of finding a way of operating, living and studying and working safely with this virus circulating. The national policy environment has changed. I won't go into detail on that, but everything from care home visiting to schools and the testing arrangement has changed, and we are going to continue a massive ramp up of testing as a public health tool of asymptomatic people now that we know much more about its reliability and usefulness, and that's rapid antigen testing. In the right environment, it does work. It will pick up people who are at the peak of the infection curve, if you like, and that's, you know, good enough. I'll skip some of these slides because I've covered them. So we have 9 local things to do. The first is we have to keep going with the maximum uptake of vaccine. The second is really continue to address the inequalities across everything, and that's not just vaccination, but that's across ability to self-isolate. Continue to ensure test, trace and isolate works as a system. Now, we do very well on contact tracing in Hertfordshire. You are going to see a ramp up in self-isolation support and work. We've already invested 2 million into helping people self-isolate through discretionary grants. There will be more coming this month and next month in terms of support. We have to keep articulating that combination prevention, which is the, you know, hands, face, space, hygiene in every setting. At the minute, we are rewriting every single programme, including how we work with businesses, how we work with faith communities. We have stood up the Events Advisory Group again. We've obviously done a significant amount of work on schools. The next big tranche of work will be preparing businesses to reopen when they are ready to reopen. So it's a careful and cautious reopening, because if people go too fast, we will see a rise in numbers. We will see a rise in numbers anyway because of social interaction as we ease off. We want to keep that rise as low as possible until we can really exit this pandemic altogether. So my epidemiological assumptions are we're on the exit path. We have to plan for a big surge in autumn and winter because it would be prudent to do that, and we have to plan for the worst case scenario. But we have to level with everybody that if our residents keep doing what they've been doing, we could avoid that. It is possible that we can avoid that, provided we keep going carefully. And that's what we want. We don't want another big surge in autumn and winter, but we'd be foolish not to plan for it. So we will see this being turbulent for some time. Test, trace, isolate, vaccinate, hygiene, these are all the essentials going forward. I'll skip over the system assumptions, but I think over the next year, we've probably got 3 big priorities as a system. The first is to exit the pandemic and plan for running COVID response alongside non-COVID work. We also have to plan for a major COVID surge in autumn and winter. We must do everything we can to prevent it, but it would be foolish, given the nature of this virus, not to do that. We should also realise that we're living in a world of new variants and recombinations. So the wild type that is now circulating across England is the Kent variant, which is more transmissible. The South African variant has a footfall. The Brazilian variant has arrived. So every time somebody gets infected, the virus gets a lottery ticket to escape the vaccine. So the vaccine is only going to be at its optimal effectiveness if we give it a helping hand. So exiting the pandemic is really crucial, because this time next year, I want a health protection strategy for Hertfordshire where COVID is one thing among others, not everything. Because we still have measles, we still have flu. You know, some of the good things is we've seen very few food infection outbreaks, we've seen very few flu infection outbreaks because of the hygiene measures people are taking for COVID. So we have to keep on going. Then a big priority for us is to recover and restart our services. I'm not going to go into detail about that for time, but we are going to have to use our intelligence and analytics capability, and we need to ask ourselves, have we got the right capabilities there to be intelligence and evidence led across this, you know, applying population health management principles, not just in healthcare, but in social care and across all our public services. And the third big priority is Build Back Fairer. We really have to kind of work on that, particularly in terms of wider determinants of health and resilience. And in terms of a COVID timeline, so I've compared the government's timeline on top with what I think is the Health Protection Board timeline on the bottom. That great big blob there of delivering safe elections, we have put huge effort into that. So that we will work in Hertfordshire to deliver safe elections. All 11 authorities and the returning officer for the Police and Crime Commissioner elections have determined that we will make that happen, and we're already on it. We've already got a team in place, we've already got guidance in place, and so on. But as you can see, as things open up, every step of the opening up plan along the top gives an opportunity for this virus to surge. We must be ready to deny the virus that opportunity. So we have to refresh all our plans. We have to embed the new health protection arrangements and then exit and review and sustain. So this is going to be even busier for us than it was during the massive surge. This is a kind of not particularly well drawn overview of the year. Where
so one second, Jim. Can I just check if others got this on screen? Now, Jim, I think the last couple of slides we've lost from you. But just share, if you just share this one.
So that's a good idea for me to stop then. I don't know if you can, if I try resharing that that last slide, can you all see that? Does it come back on?
Yes, that's on.
Yeah.
Brilliant.
Yeah.
So if I just do from the current slide, so that I think is the slide I'll finish on, where we've got the government timeline along the top, our timeline along the bottom. I think every step of the government roadmap, you know, so care homes open to visitors on the 8th. There was a huge amount of preparation work that went on from Chris's team and my team on that. So we have to get ready for all restrictions to lift. Similarly, we have to be aware that we will probably see outbreaks. As workplaces go back, we will see workplace outbreaks. If we don't manage them effectively, we will add to the numbers of infections and we will see ourselves continuing restrictions. So we have to throw everything at this into working together with employers and organisations and businesses to get us safe. So this is probably going to be an even more intense period of activity than the period January to December. I'll stop there, Chair, and I think the slides will be placed online and come out to members.
That would be really appreciated, I'm sure. Thank you, Jim. If that comes off screen now, but that's fine.
It's taking a.
Can I just say, Jim, thank you. I've already seen the election advice. That looks comprehensive, well thought through. That's appreciated. And I suppose just a reflection from me that presumably as the numbers come down, the opportunity for really managing the contact and tracing and tracking, the opportunity to do that as effectively as possible must increase. It must almost be an exponential increase in the ability to do that. And so you're nodding vigorously. So that's really helpful. I can understand why we'll be so busy in that area. Chris, you wanted to come in?
Yeah, thank you, Chair. Just to reflect that the patterns that Jim's outlined were seen in social care, but to be clear, the second wave took another very, very difficult toll within people in receipt of social care, both within care homes, but also people with learning disability, disproportionate impact. That's been extremely hard for staff and so forth. But what I wanted to say was we are seeing in very real terms and in real time the rate of outbreaks in care settings, which I think are a good measure of how the vaccination programme is going, given the high uptake of vaccine in those areas. We are seeing a very, very quick reduction in outbreaks and number of cases, quicker than we saw the first time round in terms of the first wave. The overall wave in social care was less severe than the first time round, I suspect, because of the development of PPE testing and so forth that was developed for the second time. We wanted to pay tribute to care workers that don't always get the shout out that they deserve in terms of the work that they did in the second wave. And then finally, just to, I think, stress a point, and I'm sure Christine and colleagues would agree, is that we are as a system working very closely on planning for further waves and really very enhanced winter planning. That's something we do in health and NHS circles every year, but clearly we're working on that again. Obviously, we're hoping for the best, but we are absolutely planning for what a further surge would look like, and a careful balance between what COVID capacity, for example, that we reduce, but doing that in a way that it can be ramped up again if necessary, because a lot of that capacity is very complex to start and to initiate because of the nature of the virus. So we're being very, very careful, and probably, you could describe it as prudent in terms of how we plan that capacity, because we're planning on an assumption that it will need to be turned on again. And we're doing that in a way that we can react quickly, because what we saw, I think, very clearly was how quickly we suspect the new variant hit, and how quickly it went from a position of relative stability in October and November to a very difficult position in December. Very, very quickly. And what we don't have is very much time when that happens to get complex capacity up and running. So we're taking a prudent approach in how we manage that capacity so that we can get it up again where necessary going into the autumn, both across acute care but also out of hospital care too.
Thank you, Chris. Again, just emphasising, it is. The impact of the second wave had barely impacted by mid-December, and we're right on the way down, as Jim has reflected, and it is really sobering just what an impact that had across care settings, not just in care homes, but in learning disability homes as well as supported living home. It was right across, and whilst the ultimate impact wasn't quite as high as the first wave, it was certainly significant for those residents and for staff as well, and that is something that we will be reflecting on, I'm sure, during the year to come. I don't see any. I'll just come back into chat. I don't see anybody indicating by hand, but just come through into chat. That's fine. Thank you so much, Jim. That's really helpful. Yeah, lead us safely into the elections and out the other side, and that will be really appreciated. And the wider agendas right across our communities that you highlighted, where we need to really pick up the pace. I think we've all heard that. That's really helpful. Thank you. I suppose we should. Yes. Does anybody object to noting that report? No, they don't. That report is then agreed. Thank you so much. If we move to item number 5 now, I'd like, assuming Simon's here, I would like to introduce Sam Patterson, who's Head of Integrated Health and Care Commissioning, particularly on the mental health side, and Catherine Linhart, Interim Head of Mental Health and Learning Disability, at the Integrated Care Partnership, HPFT. If you'd like to show yourselves and can introduce our next agenda item, which is on mental health and learning disability, a response in support. So who have we got?
Thank you, Richard. Yeah, both Kate and I are on. We've got half a dozen slides we would like to run through just very quickly that I will just share.
Thank you, Simon. It's actually quite unnerving introducing somebody you're not absolutely certain that they're with us.
Yeah. So yes, as Richard said, we've got a report here to talk about mental health and learning disability, the COVID-related demand, and our strategic response to that. So very much following on from the conversations that we've just had about COVID demand more generally and the pressures across the system. So this is a slide that we've nicked from another area, but is just a sort of general overview of what we expect in terms of COVID demand. So initially we saw a big reduction in mental health referrals and the number of people accessing mental health services across the system. And so we've seen that come back. And then we're also expecting a significant amount of extra demand being generated through COVID, both directly from people's experiences and then all the further impacts, the impact of unemployment and the impact of the lockdown and all sorts of other things. So that is the general principle, and I think that has been the subject of lots of conversation across all sorts of bits of the country and in the press and so on. So we've been thinking about this locally, and we've agreed that we'll bring niche consulting in to do a piece of work for us to help understand this much better. Both to understand the current and potential impact of COVID across the system, both on demand for services and our capacity, because at the moment services are working differently because of COVID. Understand that profile of needs, so we know COVID has had a particular impact on particular parts of our community, whether that's people from lower income or Black and Asian minority ethnic groups and other areas, and so think about how we can mitigate that. And then think about how we mitigate this as a system, both in terms of our existing resources and then what we might need to do in terms of future funding. And we want to do this both in terms of existing services and then sort of treatment type services, but then the whole population type approach as well, the public health side of things, the impact on district councils, on the police, on the voluntary sector and everybody. And so that element of it, I think, is a huge part of our response and something we really need to focus on. So some detail on how this piece of work is going to happen. They've got some activity information. They're doing an overview of all the research out there, benchmarking information, lots of conversations with stakeholders across the system in terms of people's experience on that and thinking about how other areas are responding to this too. So our timetable is we've started all this work, started in February, very much the data gathering side is underway, a lot of that stakeholder engagement is underway. Niche have had a number of conversations now with people across the system. We've got two bigger workshops that are going to happen, the first in late March and the second in mid-April, to try and bring people together, understand where we've got to and where the potential where the outcomes of the piece of work might come, and then we're going to take that to the Integrated Care System Partnership Board, hopefully in May, to summarise all of that and to think about our next steps from that. So that's the timetable for all of that, and then Kate's just going to talk about what we've done already in terms of response.
Okay, so as a reminder, we've already had many areas of transformation work underway through the Mental Health and Learning Disability Integrated Care Partnership, and that's got members from the NHS, statutory, local authority, voluntary sector and experts by experience. So we need to make sure that we have a whole system approach, building on what we've done through COVID that works with all of our partners. So, as Simon said, including the police, district councils, other community stakeholders, and certainly community groups and leaders themselves, to make sure that we can really understand and fundamentally co-produce transformation going forward. So if we just move to the next slide, please, Simon. Thank you. So as you can see, we've got 3 key areas of focus under the partnership. So one of them is COVID, one is transformation, and the other is the partnership development. So some highlights of what we're doing in response to COVID is we've put the wellbeing support in place for staff across the health and social care sector. So that would be for statutory, voluntary or private sector staff. We need to make sure that our workforce is resilient and that we can promote their wellbeing. But we recognise that carers and informal carers need a similar offer to sustain them within their roles. All our services have remained open during the recent wave, and we've continued to offer virtual support. We'll be evaluating those offers and building on the opportunities going forward. And we've again had some funding available going into next year to be able to extend our virtual support offer. We're focused on facilitating faster access to crisis support and reduce the time that people with mental illness and learning disabilities spend in A&E. In terms of transformation, just this week we've been meeting with the PCNCDs to take forward a new opportunity for mental health workers to be embedded within the primary care network. So that would be as early as July. That's a really exciting opportunity, and that builds on our wider adult community mental health transformation. So key focus of that transformation is ensuring people can access the right support when they need it through any door. So absolutely dissolving those barriers. And we're co-producing that community transformation model now and for implementation in April 22. Children and young people, we've extended the 24/7 crisis support offer, enhanced our response to children with eating disorders. We know that that's a significant issue at the moment that has really grown throughout COVID. We continue to build on our school trailblazers and enhancing the access to early help and through the development of the pathway and continuing remodelling of our CAN services. We started the Crisis Care Partnership, which was formerly the Crisis Care Concordat. So we've restarted that, and we're currently working to set priorities over the next 6 to 12 months. We've been awarded 100,000 to enhance our suicide prevention work, which will support the work that's already going on in that area. And then just some other key areas of focus are health outcomes for people with learning disabilities, inequalities, including ethnic inequalities in mental health care, which has been a long-standing issue, and digital. So as I said, really looking at how we can enhance the care and support that we can offer and the wider work, preventative work we can do through utilising technology. So I will pause after that, and Simon and I are happy to take any questions.
Thank you, Kate and Simon. That's excellent. I think we, if we kick off with Paul, and then I see Jenny has indicated as well. So that would be great. And good morning, Jenny. I didn't say hi at the start of the meeting, but good morning to you, Paul.
Thank you very much, Richard, and thank you very much to Simon and Catherine for setting out the work that's being done. Just a couple of observations and things from me, if I may. One was just to draw attention to the potential range of costs that are described in the report, both in terms of the next 12 months and the next few years, circa 15 million in the next 12 months and 9 million thereafter. I just want to emphasise those are, I think, the direct costs in terms of a service response. I suspect there are other wider costs in terms of the economy, in terms of employers, in terms of sort of social costs. So I think there's a bigger cost building there, which I think we need to have an understanding of because I think it further, if you like, underscores the need for investment in order to mitigate those risks. I also very much welcome the emphasis that was being given on both prevention and public health strategies. This needs to be absolutely embedded in all of the agencies that are sitting around this virtual table, in their thinking and their strategizing and their plans, and particularly in terms of how we look after our own people in our own workforces. And I think it also is something for me that critically here, we have to find ways of making sure that this is non-pathologizing and non-stigmatizing. That much of what will be needed is about how you help people respond in what is a very natural way to the trauma of living through a pandemic. And whilst there will be those that will need access to mental health treatment services, no doubt of that, we're seeing that in the statistics that Catherine and Simon have already referred to. I think it's really important that that's the tip of the iceberg, and we need to be keeping our eyes on what sits beneath and what we can do to mitigate some of the impacts on that wider population. That's why I was very keen from last summer to ensure the ICS was focusing on this and asking questions about this. That's why I'm really pleased that we now have Niche Consulting doing this work. I hope they're going to engage, and this is my question. We obviously have a number of stakeholders from a variety of agencies around the Health and Wellbeing Board table. It would be good to know that all of those agencies are part of the list that Niche will be talking to. Certainly, I have a call with them later this week. Thank you very much, Rich.
Here, Paul. That just makes so much sense. Jenny, and then Teresa.
Hello, thank you, Richard. Really, just following on from what Paul was saying, that there's a whole range of services and support out there, particularly for children and young people, which is not mentioned in the report. A really good report, and thanks for that. Like our own YC Hearts do a whole range of groups and have continued to do face-to-face contact throughout the pandemic. The really good news that schools have started reopening fully again, and all the work that will be done in terms of supporting children through their everyday work, but also, as mentioned, mental health teams in schools. And we've had DFE money go in to help train teachers, and we've got a whole series of tools which have been created by Hearts for Learning, as well as the voluntary sector. So I think it's really important that although this work is particularly thinking on the high end of emotional health and wellbeing and mental health needs, that there's a whole range of services out there that are there to support people at early stages and build on their resilience rather than things waiting for a crisis. And I know, Simon, some of the work you've been doing has shown that indeed people haven't accessed those preventative services, and therefore their issues have got more serious. So I just wanted to say that there's a broader band of support here in emotional health and wellbeing. Thanks, Richard.
Thank you, Jenny. Teresa.
Yeah, Jenny's sort of taken the words out of my mouth, but we do talk about these things quite a lot, so it's not surprising, is it really? So I totally endorse what Paul and Jenny have said, particularly around Paul's comment about non-pathologizing. Not every child needs to go into the CAM system, but they do need help potentially, and I think it is very important that we ensure that Niche look at everything that is done in the county for young people. People do not realise what's out there, and we're not very good at communicating it. I have to say we're not, and it's quite difficult, and people don't, and they have to try really hard to find out about it. So that's something I hope that will come out of this piece of work: how we can communicate better, how we can make sure the whole system knows what's going on. So, you know, I know that my particular PCN doesn't really know what goes on across the system, especially at that lower everyday level. So that's really important. Yeah, no need to say any more. I mean, that's the thrust of it, really. Let's make sure that this report covers absolutely everything. So once and for all, we have everything down on a piece of paper somewhere so we can make sure that it's shared in the most appropriate way. Thank you.
I'm just checking. Jenny, did you want to come back, or are you still, is that legacy? That's fine. Sarah, please. Thank you. Teresa, thank you. And I'll pick that up just summarising, but thank you.
Thank you, Richard. Thank you. Yeah, my comment is in a very similar vein, really, which is that absolutely it's important that this report looks at individuals who will be accessing statutory services, but actually there is a huge swathe of the population that is almost suffering a hidden mental health crisis. And a lot of those are individuals who will never consider accessing mental health services for a whole variety of reasons. If I think about the older population, a group that I particularly work with, there isn't a stigma about mental health. It's just that they deal with things often in different ways. And actually, I think recognising that we together as a whole system, particularly the VCSE, how we together build confidence in our community is a huge part of this recovery period of time. So I think if we don't overtly talk about it, and if we don't set up systems and actually recognise that support needs to go out to these people, it may not happen. And I am particularly concerned about individuals who are so lost confidence that they are not accessing anything in the community at all. They are not going outside their doors. They unfortunately will also perhaps be developing a lot of physical health problems. So I think that's probably the last thing that I would say. I think that we do need to again look at the interrelation between the mental and physical health problems and how they can be connected.
Thank you, Sarah. And Elliot, you wanted to come in as well.
Yes, thank you. I wanted to come in around a similar point to Sarah, but particularly relating to children. And again, looking at the wider scope of that. So not just focusing on mental health and at the more severe end of mental health, but actually around what I would call children development, and being clear that the mental health of the capacity of children to learn is dependent on a stable mental health position, and also that they get access to audiology, to vision services, to ophthalmology, to various other services. So I think there's a whole child development agenda, and we've had children out of school for a long time, that we need to pick up coming out of this crisis, which isn't about mental health, just about mental health. Yeah. But it is significantly about making sure that our children develop in the way that they need to over the coming years. And I would point out at the moment that the services that collectively I would put into that category are 30% less used than they were a year ago. So it's a significant gap that we need to pick up. It needs to be probably in the work that Nish and others are doing. It needs to be referenced because it's not directly in scope, but I think it needs we need to acknowledge those outer borders and those outer links.
Elliot, that's almost like common sense, which is frightening for a health wellbeing board. But absolutely, the sentiment of what you're saying is that there is a hidden need. Because we have all been locked down, there is there will be a reaction in different age groups. I just have COVID fog. I haven't got a clue what you all just said, but I'm hoping that in the next year or two my memory will come back again and my cognitive abilities will return. More seriously, what Sarah's referring to, and Jenny, at both ends of the spectrum, people have got to come back from a strange place. And their needs are probably not fully understood yet. And we need to be ready. This report will really help. But there is my sense is the report will need to have a short-term impact, but also a longer term as well, so that some of that need might express itself long past the lockdown. I'm probably seeking some further input there from perhaps Simon or Kate, but I think that's why, for example, in terms of communication, picking up Teresa's point, we've had really great success with communication, for example, through Heart's Help. Is that now best placed to deal with wider community need? And there'll be a range of activities. But have we got the post-COVID setup right? But I think this paper is excellent at highlighting just what the demand might be around high anxiety and stress, particularly around the general population, as well as those in more need. Now I'm starting to feel like I'm banging on a bit, but thinking back to learning disability, these guys have been literally locked in their homes for a long time, and the support to help them back out into the community will be really high. So enough from me, I think. Are there any more who wish to add anything? Could you just come back on perhaps a comment on what the report might do in terms of addressing that sort of longer term coming out?
Yeah, thank you, Richard. So, I mean, we know the impact for some of the areas will be quite long term. We know PTSD can take a number of years for people to seek help. So part of what we're looking for Niche to do is to get some idea of what that tail might be, so we can see that there will be a significant initial impact from COVID, but then potentially quite a long tail of additional demand, quite apart from the additional impacts of things like increasing unemployment rates and all that sort of thing, and things like bereavement support as well. Also, people can take some time to seek that sort of support too. So that very much is part of what we're looking for the report to do, and that we need to think about longer term, and does feed into the existing NHS long-term plan priorities, and making sure that we're supporting people across a range of services.
Thanks, Simon. Kate, I tell you what, let's take David and then Kate. Thank you.
Thanks very much, Richard. I mean, clearly we've got a lot to learn from COVID, and every single service that we represent will have much to learn from it. And I am interested in the report. And especially welcome the work which is underway. I mean, that's brilliant. Certainly from a constabulary point of view, mental health has long been or poor mental health has long been a cause for concern. And we know all about the sort of the care concordats and various other things that we've done to try and work together. I would push that we need to look at that again as part of this piece of work, to make sure that we are doing the right things by those who suffer poor mental health and specifically are in crisis. We can't know, and there's the linked issue, and you'll know my passion around getting it right around domestic abuse. There is a linked issue around domestic abuse here as well, and to an extent we don't yet know. I was chatting to Teresa and others yesterday. We don't yet know where that's going to lead us, whether or not there's a huge domestic abuse crisis in the system, but actually the report hasn't yet come back, or whether or not it hasn't happened because we're getting different warning signals which are different to what the reality is at the moment. That perhaps goes off this specific point. I think the big point I'd want to make, and the only reason I intervene, is I think that those of us who are decision makers have got to take a decision to work closely together around this, and to make sure that our services are better lined up together to support. And you'll know, although there hasn't been a paper yet to the Health and Wellbeing Board, and if I'm around after May, I'd like to do it, and if I'm not, potentially my successor would like to bring a paper to this around our prevention first agenda, which I see very much in that whole public health approach, which says let's avoid the crime happening in the first place. And actually that too seems to work very well alongside much of what's happening here. So let's make sure that we use the information we get in a really positive way. Let's use the information so that we start making more joint decisions, using budgets jointly and using our offices jointly, so that we can actually have that whole prevention first agenda, not just around public health, but also around crime. And I think that, that this is a real wake-up call for that. And I think if there's something positive that comes out of, there are many positive things that will have come out of COVID, but if actually in doing that we get this whole prevention first agenda, that will be something really, really worth having.
There we are. Thank you, David. I'm not sure there's that many positive things come out of COVID, but I know the point you're making. Kate.
Yeah, it was just on the longer term. So it was just really being mindful about the generational impact. So what we do now being absolutely critical, because we're at a key point now. We've been through something, that we've never been through before as a society, and we can recognise the impact on mental health, and then the links that mental health has to other things like domestic abuse. But that will ripple down over generations, so it is absolutely critical that we do everything we can now to support, treat and prevent.
Thank you, Kate. I don't have any more speakers indicating to speak. Shall I just a few recommendations here, and we might want to just add a couple more, but note the high level national demand modelling applied to the HWE system. Consider the approach set out to furthering the modelling and understanding of future demand and need. That is what niche is doing. Consider the role of the Health and Wellbeing Board in supporting progressing this activity across Hertfordshire. That covers much of it. But I think there is something in there about evaluating communication and links in the system, which includes all of picking up the point about if we are the leaders, just make sure that we've all been included in this and our organisations. I think that's where I would leave that as recommendations. Just one other area that I would like us to pick up is around vulnerable adults. Always that defining that group of vulnerable adults might be slightly different post-COVID, but in reality they are going to be highly needy post-COVID, and I think we should really look at that through both vol sector work that we do and our supporting through mental health. And all it remains for me to say is to thank you both to presenting this today. Also the very fact, picking up David's point, that we're getting on with this through niche. Thank you for initiating this work and being on the front foot, both in community need, sort of broader community need, but the specialist need as well. And you highlight just what's here. And I suspect as board members, we'd want to know what we need to do, and then we'll see about when we can find the money. I'd like us to be asking, what do we need to match the need, rather than the other way around. So that's my say that we can do everything possible to meet the need that's identified through your work. Great, thank you so much. Can I just could I ask everybody to could you either agree, abstain, or disagree with that through chat? I'd be grateful. Thank you.
Richard, Avni's got her hand up.
Sorry,
right.
Richard. I can't seem to obviously put anything on chat, it says, because I'm not a member. So just to say that I agree. So.
Thank you, Avni. Was there any, my apologies if I didn't see your hand raised, but is there anything further you wanted to add?
No, I mean, I think it's absolutely the right thing in terms of the direction of travel. And obviously, we've been working closely with Simon and Kat around all the work around mental health and LDs and stuff. So absolutely, we welcome this approach with the niche.
Fantastic. Avni, thank you so much. Nobody's agreeing with that. That moves through. Simon and Kate, thank you so much for introducing that to us, and look forward to, I think, let's get an update in the not too distant future. Thank you.
Thank you.
Which brings me to introduce Ed Knowles, who is the integration director across HCC and with Hearts Valleys. And this, I think, should be quite a quick item, which is to update on the Health and Wellbeing Board strategy, which COVID has pretty much destroyed our progress on. So, Ed, what should we do next?
Thank you, Richard. Sorry, let me make sure the headset is in.
You're good. You're good.
Yeah.
You're good.
Fantastic. Yes, short report and hopefully a short presentation from myself. So members of the board will be aware that we have a statutory responsibility to have a health and wellbeing strategy for our local area. And in January last year, which is the last time we all physically met, for those of you who can cast your mind back, that was snow in the car park in the Focolare Centre. We considered a report about the steps we wanted to take over the course of 2020 to re-engage and to do the required consultation to make sure that an updated health and wellbeing strategy properly reflected the needs of Hertfordshire, the issues that we were facing as communities, and we had actually initiated a series of workshops with our district and borough health and wellbeing partnerships to start that process. Obviously, COVID came along, and as a consequence, that activity was paused, and we haven't picked it up since. I think it's probably worth recognising that, it goes without saying, obviously, that the context in which the health and wellbeing strategy is now being written has changed fundamentally. Interestingly, a lot of the priorities will still be our priorities, but the issues have either been exacerbated or in many cases, obviously, COVID has highlighted inequalities in our communities that we absolutely need to make sure this strategy addresses. So our new health and wellbeing strategy is going to have to look at that. It's going to have to reflect upon the partnership working that we've seen take place over this last year. And importantly, given what the white paper has indicated around the future of the ICS, we're going to have to make sure that the health and wellbeing strategy helps to provide that context and direction for the integrated care system as well. So we have work to do this year around this. We will be pulling together a plan as to how we do re-engage around those issues, around all of the cells that have taken place across the COVID response. But I suppose I'm here today to ask for the board, to recommend the board extend the existing strategy for another year to allow us to have our strategy. The intention is obviously to make sure it won't take a whole year to get a new strategy, but I'd like to make sure we have enough time to do the consultation engagement properly. And so this allows us to remain statutorily in line while we get the rest of the work done. So that was it. Recommendation to note the report and to extend the strategy for another year to allow us the time to pull together the strategy that we need going forward.
That's lovely, Ed. I can't see anybody indicating to speak. It's pretty straightforward. Thoroughly support the recommendation. Just note whether that's agreed or not, and then we've done it formally. That would be great.
Would like to come in, I believe, Richard.
Sarah.
Thank you very much, Richard. I just had one comment to make. I mean, the VCSE sector has already started to consider how it can be a part of the new health and wellbeing strategy. But I just wonder whether perhaps we are missing a bit of a trick together by just rolling this forward. It had sort of concluded in 2020. I wonder whether we could perhaps agree that we should have an additional element, which is recovering well. So, obviously across the whole life course, that's a very appropriate approach for all of our institutions to take. But actually, as well as starting well and developing well, living well and aging well, recovering well is what we are all now focused on. So I wonder whether, in fact, together, as a health and wellbeing board, until we have the new strategy starting in 2022, recovering well could be the joint theme that we sort of continue to put our effort into.
Yeah, to be honest, Sarah, I don't think anybody's going to disagree with that. I think that was our previous item was reflecting that, and all of our organisations are looking to address, to look at their services, to tweak them to do exactly what you suggested. So I can see no reason why that couldn't be included as part of the recommendation. That's excellent. Thank you, Sarah. And I think as an aside, the County Council has increased its budget for the voluntary sector, really reflecting the need that may arise right across the community, and just thinking about how communities build back resilience after COVID, and again reflecting on the previous item about the wider population need. So that's fine. That is fine. Good. I can see that's all gone through, and that looks to be agreed. Thank you so much.
Sorry, Richard. We haven't actually got 10 votes in. We need to have 10 votes, please.
Can somebody vote twice, please? No, seriously. Okay. How many have we got? Oh, we've got a few more coming through now.
Yeah, I've got a few. Yeah. And just to confirm, Avni, you can vote because you are subbing for Jane.
And
Yes.
and Avni was indicating her agreement. Yeah.
I'm just giving a thumbs up. That's all right.
There we are. Again, just going back to my comments at the top of the top of the meeting. That the white paper does give us the opportunity to work ever closer together, and I think if we are to address our health and well-being needs, well, that is a vehicle for doing it. Thank you so much. Unless there are any further comments, which I don't see indicated at the moment, can I thank you so much for your input, particularly our presenters today, to give us the update around what's happening with COVID, what's happening with the vaccination programme. Really quite uplifting. It's been a traumatic couple of months, and yet at the moment it's looking, we're going in the right direction, and it's really quite positive. I want to wish our acute hospitals all the very best as they start to ease out their COVID patients, and good luck with those that have really struggled there. And of course, then ease back in the elective programme, which has been suspended for a while, and we know the backlog of health need that will be out there. But I would like us to end on a positive note. That actually both health wellbeing right across our sectors here, and they're all represented in the room, not only have done brilliantly through COVID to either minimise impact or to be supportive. I'm thinking of Sarah in the Vol sector here and Steve Palmer in Health Watch being supportive with the work programmes, that we find ourselves on the verge of release and really ready for the next phase of post-COVID. I know, Jim, if you're still there, you'd be batting me around the head saying, no, got to be very careful. But I think we're in our population is ready to break out and resume some normality. Thank you all. Thank you guys for helping us to get.
Would I do that to you, Chairman?
Right. Thank you so much. Really appreciate it. I think we can close the meeting now.
Thank you.
Thank you. Bye.